Hello, everyone. I'm Carmen Pugliafito, and I'm here today with Professor Pearse Keane, who has got a unique, I think, professorial title, Professor of Artificial Medical Intelligence at University College London. He's also a consultant ophthalmologist at the Moorfields Eye Hospital. Pearse, welcome back to Retina Synthesis.
Thank you. It's a real pleasure to speak to you again. I'm looking forward to our conversation.
So today we're going to talk about the role of artificial intelligence in the management of macular diseases. Can you give us an overview of what artificial intelligence is and where it might be going in terms of clinical medical retina?
Well, so I guess there's lots of different definitions of artificial getting computers, getting machines to do things that you would normally think would require human intelligence to do. And this was a term coined in the 1950s, maybe 15 years, is that a type of artificial intelligence called deep learning has become another way to describe something called artificial neural networks. And these are computational models that superficially resemble human neural networks in the way that they process information. And so we have started to see those come into healthcare settings and particularly in ophthalmology settings. The reason for that is that they are very good at analyzing high dimensional data. And so by high dimensional data, I mean something like a retinal image or an OCT volume. And so, for example, an OCT volume is, as you know, of course, is essentially like, it could be like 50 million numbers in a three-dimensional grid representing the voxels of the OCT. And what you can do with AI is essentially you can put all of that data into an artificial neural network and teach it something about that data. So you might, for example, teach it to do a classification task. So in other words, teach it to help with diagnosis or screening or triage or predicting outcomes. Or you might train it to do something called the segmentation task. So effectively what you do is you train it to look at each pixel or each voxel in the scan and say what it thinks it is. So maybe, does it think it's intraretinal fluid or subretinal fluid? So in essence, in ophthalmology, we can use it for screening and diagnosis, or we can use it for measuring things or predicting things. Now we're starting to see, of course, lots of AI in ophthalmology. The first two entirely autonomous AI systems to get FDA clearance were in ophthalmology, both for diabetic retinopathy screening. And then we have a number of companies in macular disease focused on OCT that are focused on providing different measures of, for example, intraretinal fluid, subretinal fluid to manage anti-VEGF therapy, or increasingly automated measurements of the retinal pigment epithelium and the outer retina to manage patients with geographic atrophy and dry AMD.
Tell us a little bit more about the approved systems for management of wet macular degeneration.
Well, so I'm not too well versed in the systems that are approved in a US context, but in a European context, there's a number of systems. There's a number of companies. So there's a company called RetinSight, which is founded by well-known retinal specialist called Ursula Schmidt-Erfurt, and that has recently been acquired by Topcon Healthcare. And that does measurements of fluid and things to help with anti-VEGF injections, but also a bunch of others. So a company called RetinAI, founded by a computer scientist called Carla Siller, which is based out of Switzerland. And that has also been used particularly for pharmaceutical post-hoc analysis of clinical trial data and trying to like stratify patients and so on. And then there's a couple of other companies. There's a company called Mac that does similar deep eye, which is purporting to do something similar, although I'm not very familiar. And so I guess these systems are potentially quite exciting, although I think it's fair to say that none of them is, or at least to my knowledge, is in widespread use yet within a European context. And that is because I think that there's still a degree of uncertainty around what the business models of these systems would be. And, is it useful and is it worthwhile to pay to get a better measurement of intraretinal fluid when you're giving an injection, for example? So I think that that's still open for debate.
Well, there is complex decision-making in anti-VEGF therapy and anti-Ang2 therapy. We need to clarify that these days. And in that complex clinical decision-making, will that become autonomous, do you think?
Well, so I think it's complicated because there's very different regulatory considerations for a clinical decision support versus an autonomous system. And so I think that the sort of the health economics would favor an autonomous system, because that would potentially save labor costs and so on in doing the assessments and so on. But I think most of the systems, to my knowledge, are clinical decision support. And so they just help retinal specialists or other ophthalmologists with more precise measurements of fluid. And I guess the people who develop these systems would argue that that is going to lead to better outcomes for patients. It might lead to, it might avoid undertreatment, or it might avoid overtreatment in those patients. But I think that evidence, at least in my opinion, remains to be seen.
So in terms of clinical decision-making support, what about a model in which factors such as visual acuity is connected to anatomic response?
Well, so I think that visual acuity should really be taken into account, and I sometimes worry that ophthalmologists are just obsessed with getting the macula dry, and sometimes I wonder about when we have these patients, and they have a tiny bit of subretinal fluid that's persistent, but their visual acuity is still 20/20. Should we really be as worried about them as perhaps we are? I think that that's one thing. But then the other thing I would say is that I don't think that these systems necessarily address some of the clinical complexity in decision making, because they essentially measure fluid and so on. But actually, a lot of the time why you need specialized retinal expertise, at least in my opinion, is because sometimes you have conditions that are mimicking AMD that are not in fact AMD. Maybe it's choroidal vascularization from other causes, or maybe it's something else like central serous chorioretinopathy, or it's something which is not choroidal neovascularization, but is some mimic like a drusenoid pigment epithelium detachment with vitelliform lesion. And
Right.
The AI systems will just quantify the fluid, but they won't necessarily tell you that this is actually something that is a completely different condition that you should be considering, in my opinion.
So there's a role for ophthalmologists in terms of interpretation.
Yes, of course. Of course, I think so. Yes.
Treating the OCT is a controversial subject. And I've often said that treating the OCT is probably not the best, unaccompanied treatment of the OCT is probably not the best approach. And I think even in the world of artificial intelligence, the brave new world of artificial intelligence, that is correct.
Yeah. Well, so I mean, I think we've all probably seen patients where they've been attending a different doctor and somehow you end up seeing them. And I've seen a patient who's received 70 anti-VEGF injections, and I took one look at their scan and I'm like, this person does not have wet AMD and probably didn't need most of these injections. And
Would they have the vitelliform lesion?
Vitelliform lesion or something of that nature. And And oftentimes you talk to the patient and you say, "Oh, when you first presented, did you have problems?" And they say, "No, actually, I didn't know anything was wrong with me, but I happened to have an OCT scan done, and then suddenly I'm getting 70 injections." And then you tell them, "Actually, I think we can just pause with the injections and, take a break." And then they almost want to hug you because actually they've been wondering what's been going on for the last 3 years.
Mm-hmm. In terms of quantification and profiling of OCT, what kind of information are we going to get back from the clinical support medical intelligence systems?
Well, I think at the moment it's relatively limited cross-sectional information. So it's just a more precise measurement of intraretinal fluid, subretinal fluid, drusen, atrophy. I guess there are some companies that are trying to work on other more sophisticated things like predicting progression or predicting treatment burden or predicting visual outcomes. But like I say, I remain to be convinced on whether these will really benefit.
Are you familiar with the no-tell vision automated system for measuring treatment effect in neovascular AMD?
Not hugely. I don't have any direct experience of that. It's not something that we use in the UK. Um, and I certainly would be open to whether it's a good thing or not. I guess, my default position, and you may vehemently disagree with this, but is sometimes we have these patients, at least in the UK, and they're getting injections every 4 weeks or every 6 weeks, and I just wonder if it would be a struggle for me to tell them that we also, in between your appointments, we want you to go and scan yourself every day at home or something like that. Yeah.
Well,
So
that's where the world revolves around practicalities and logistics,
yeah, yeah,
and
yeah,
uh, we can have the best data analysis in the world, but if the patients aren't compliant with
yeah,
its implementation, that's difficult.
yeah, yeah, yeah. It's true.
So geographic atrophy 20 years ago was not a subject of treatment interest. And even 5 years ago, it was just emerging.
Mm.
How can artificial intelligence help us in the domain of atrophic macular degeneration?
Well, I think I mean I think clearly, as with anti-VEGF, there may be a role in just simply providing better measurements of the atrophy, and thereby perhaps helping support some of these treatments that have become available. They're not available in the UK, but used in the US. And so, if you have a treatment which hasn't been shown to give functional improvement, then I guess you probably want to have some sort of way to tell your patients that the treatment is having some benefit, that it's slowing down the progress of the spread of the atrophy or something of that nature. I guess the holy grail beyond that, though, is can we somehow use this type of big data to better stratify patients so that we can identify some phenotypes, and those phenotypes are the ones that are more likely to progress, and therefore you have a stronger rationale for giving them a treatment which is invasive.
Uh, any ongoing clinical trials in this realm?
So I'm not. I guess I'm not directly involved in recruitment for trials. I tend to be more on the sort of early stage AI type things. I guess where, just to maybe slightly answer a different question than the one you asked, I guess I would say that my interest is in how AI can be used to help pre-screening and screening for clinical trials in geographic atrophy. And in particular, there's a number of trials that are going on in Moorfields, where I'm based, or in eye hospitals around the world, where you have patients that are recruited with extrafoveal geographic atrophy that have small amounts of GA, and those patients are often hard to find because they're not, at least in the UK, they're not necessarily coded well in our electronic health record. Whereas actually, if you have an AI system that you can just take and plug into your imaging system, say your Heidelberg system or your Top Gun or your Zeiss system, and then you just let it run over the weekend, and it essentially identifies every OCT volume that has drusen, that has an area of atrophy, that doesn't have choroidal neovascularization, and it tells you whether the atrophy is foveal or extrafoveal, and then essentially prints out a list. And then you can give that to your clinical trial coordinators, and essentially you bring those patients in, you recruit them for the trial. That's more where I'd be involved.
Mm-hmm. So artificial intelligence could be useful in the simple task of measuring areas of geographic atrophy, which we really don't do now clinically.
Yeah.
Has anyone demonstrated that capability in the real world?
Yeah, I think that there's some of these companies that I've mentioned do have AI systems that can measure geographic atrophy. They can measure loss of the retinal pigment epithelium. Some of them can measure outer retinal thinning. And I guess one of the things that's in vogue more in a research setting is measuring the ellipsoid zone and seeing if somehow that is a better indicator. But I think it's a very much an open question as to whether that can be reliably measured using these types of tools, and whether that can be acceptable to the FDA and other regulators.
Yeah, the ellipsoid zone is obviously a critical part of decision making in treatment, and can be difficult to assess.
Yeah.
So an exciting development is a joint venture between Moorfields Eye Hospital and Topcon, of which you're one of the co-founders in the arena of medical intelligence. So tell us a little bit about this enterprise.
So it's very exciting for me that I'm the co-founder of a company called Cascader. And Cascader really comes out of the work that Moorfields established in 2016 with Google DeepMind. And essentially, we worked together to develop an AI system that could be applied to macular OCT scans that could quantify all the pathology on the scan, but could also give a diagnosis and a referral urgency for the scans. So this was a system not aimed at retinal specialists, but rather aimed at comprehensive ophthalmologists or glaucoma specialists, or even in a UK setting, optometrists. And essentially, the idea was that it could identify people with the most sight-threatening macular disease and get them referred to a retinal specialist as soon as possible for the appropriate treatment. So that technology has been essentially licensed back to Moorfields Eye Hospital to be commercialized and made into a medical device. And so that is what led to us in May of this year spinning out this company Cascader. So we called the company Cascader because first of all, we wanted a name that wasn't like retina specific or wasn't ophthalmology specific. And then we were thinking about cascade because we like the idea of a cascade of algorithms. You know, we could do retina, we could do macula, we could do glaucoma, we could do oculomics, and so on. But the problem was there's a lot of already trademarks related to cascade. And the other reason we like Cascade, of course, is because of the visual cascade and the kind of connotations associated with that. So actually, by coincidence, we were also looking at animals that have like enhanced vision. And, you know, of course, dragonflies have 360-degree field of view and they can see in ultraviolet light. And so we came across a dragonfly called a cascader dragonfly because it flies along running water. And so we said, that's it, we'll call the company Cascader. So perhaps that's too much information, but essentially we spun out this company from Moorfields and University College London, and then we've had the initial funding from Topcon to do this. The company is co-founded by myself, an ophthalmologist called Peter Thomas, who's going to be our CEO, and a software engineer called Ege Ilachak, who has a background in medical device software, who worked for Heidelberg Engineering for many years and has got a huge expertise in quality management systems and regulatory approval for AI systems. So we're really hopeful that, in the next year or so, we can actually get to an AI system that is present when you just go to your local optometrist or your general ophthalmologist and you have an OCT scan done.
So that really is the 2016 paper, the diagnostic paper, was impressive. And as someone who'd worked on OCT from day zero, I was truly impressed. So this is a way of implementing that research in the real world.
Yes, yes. And as you know, more than most, it's one thing to publish a scientific paper, but it's a very different thing to actually take things from code to clinic. And I used to think the hard part was publishing a Nature paper or a science paper, but actually, bringing things to implementation is the really challenging part.
How broad do you think the diagnostic power of this system would be?
Well, so I think the first system we would do would be mainly looking at macular disease, but I think we would want to also be able to incorporate glaucoma and other optic neuropathies, and I think that we would also want to incorporate oculomics, so using the eye as a window to systemic health. So essentially, the idea would be in the future you could go to your community optometrist, you could have one OCT scan that covers your macula, covers your optic nerve head, and that gives you macula, gives you glaucoma, and maybe you have a wide field image that covers for peripheral retinal disease to a large extent, but also the combination of the wide field image and the OCT allows you make predictions about systemic health, cardiovascular disease, neurodegenerative disease, and so on.
Yeah, no, it's truly exciting. So, when do you think the system might be available for its initial clinical trials?
Well, so we've started the process now, and watch this space. But I'm hopeful that in a year, maybe 18 months from now, we might be able to see the first certified device for this.
Yeah.
Let's see. Maybe I'm naively optimistic at the moment for these things.
It's wonderful. I hope we have an opportunity to use this in the United States as well.
Thank you.
So, Pearse, thanks for a fantastic discussion. We will be back with you in 18 months to see how your enterprise is functioning. And once again, thank you on behalf of our audience.
It's my pleasure. Thank you very much.